Can everyone hear me?
Yes, we can.
Okay. I'm going to mute everybody. If you want to talk, you'll have to unmute yourself under the attendee list. That way we may not get any audio feedback. Dr. Mills, you'll need to, for sure, unmute yourself. And then I will turn it over and we will get started. We will be recording this, so hopefully it will go great. So we will. So Dr. Mills, I'm going to turn it over to you.
Okay, great. Can everybody hear me okay, I hope? You're muted, so I guess without anything in the chat bar typed, I'll assume you can. Really appreciate the time to get together again and talk about ways to improve our practice for the betterment of the health of our communities and our practices. Today we're talking about a deceptively simple tool, which yet gets to some of the very heart of what value-based care and population health, and that is pre-visit planning and the flip side of that coin, which is advanced rooming. This talk is less detail-filled than some of my other hours with you. I think we'll have some time left over and time for good conversation to the degree that you want it. So you know who I am. We won't labor any of that. So our agenda today is to talk about kind of understanding at the very basics, maybe at even early steps that some of you have taken, what the value of team-based care is in trying to do what we're doing, consider possible goals for pre-visit planning and advanced rooming, explore workflows to move into or advance your pre-visit planning and advanced rooming, and then to answer questions. So, as is my usual habit, I like to start with the why. Why would you do a more rigorous, written down process of being prepared for visits and advanced rooming at the time the patient is up, as opposed to the traditional model, what we always do? Well, there's a couple of strains of thought. We've already talked about many of these, but first of all is the classic article by Altshuler-Rumbach, Annals of Family Medicine, and I love this one. The stress you feel at the end of many days and many weeks that we just didn't have enough time to get it done, and most days we don't have enough time to get it done, is because there really is not enough time to get it done. So this is based on a 2,500 patient panel, assuming one provider, and you can, the article actually has a spreadsheet you can download to put in numbers that make sense for you, so it's really a fairly powerful tool. And it's based on the 10 most prevalent chronic diseases, and then the time per patient, basically per day, or time per patient per year, it would take to deliver all the recommended acute care needs based on normal incidences of acute care, all standard chronic disease recommendations for the 10 most common chronic diseases, and all recommended preventative care for USPSTF standards for a 2,500 patient panel. When you divide, the data is very solid about how many hours per year that takes per patient, and you work the math backwards, it's 21 hours per day. And so you say, well, okay, I don't have 2,500 patients. I only have 2,000 patients or 1,700 patients. And when you do the math, you say, well, great, that means it only needs to take you 18 hours a day. And I have some long days, and I know you all do too, but we can't build a workflow, can't build practice assuming 18-hour-a-day work days. And so the only way to balance that is to say, well, I'm really only going to work 11 hours a day, or whatever the number is. National average right now is about 40. AFP says something like 47 hours a week, and MGMA says something like 51 hours per week. The only balance that equation is to say we're clearly just needing all of our patients' documented needs. And I want to do something about that, and I bet you do too. So this is a wonderful quote, and I don't want to belabor this, from this article, but just saying, solving the primary care dilemma, excessive panel sizes in an environment of basically raising medical care needs with the boomers, primary care physician shortage requires replacing physician-only care with team-based care. This is an unprecedented change in culture and structure that can only be accomplished through a change in mindset, the training of non-physician clinical team members, the mapping of workflows and tasks, creation of standing orders and empower non-clinician team members to share the care, the education of patients about how to interact with that type of team, and the reform of primary care payment. And it goes on to say that fortunately all those elements are being implemented in many innovative practices, and that is absolutely true. And what we're experiencing in COs, and especially what we're experiencing in CPC and CPC Plus. So this tracks back to even some earlier work. This goes back to 2008 or 9, talking about what are the building blocks of high-performance primary care. This goes back to even some of the philosophical discussions preceding formalized PCMH. And this is saying these 10 elements are how you get to high-performing primary care. And I just want to point out that it really, a foundational bedrock is the assumption that you build the tower on is team-based care. That then empowers data-driven improvement, because there's not simply one person doing everything, one person guiding every play, if you will, and that's what enables population health. And then in CPC, and I know CPC Plus, I know, or not heard that you all heard for those who applied if you're yet, this is baked into the five dominant functions, or 5 core functions and domains in CPC Plus, is planned care and population health. That then gives you the tools and the structure to take on better patient caregiver engagement, because your chronic disease care is much more orderly and planned, and it also gives you the time and space to take on much better comprehensive and coordinated care. So it all builds up. This concept of pre-visit planning and advanced rooming is really kind of the keystone of all of that. And as with many things, it's a simple concept, easy to grasp, but then as you dig into it, it gets complicated, and you really have to work at putting it into place. It doesn't just fall together past a small scale. And so let's talk about this particular piece, pre-visit planning. So what is that? You know, we all do planning for visits. In the traditional model, you looked at you walked up to an exam room with a chart in it, you pulled up the chart, and it said Mrs. Smith, and you pulled up Mrs. Smith's chart, physical or electronic, and you looked at her problem list, and you looked at her medications, and maybe you read the last note, flipping back a few pages. That was the extent of pre-visit planning. So in the context we're talking about now, pre-visit planning is the practice of routinely reviewing upcoming appointments. What's the reason for the visit? Since we last saw this patient or had contact, what happened? What other sites of care? What other specialists were seen? What will be needed at this visit? What's missing to accomplish that need? So said another way, it's all of the data, the record keeping, orders placed in advance, other steps performed in advance of the patient's office visit in order to be fully prepared for the visit before the patient gets there. And so clearly this is done typically 24 to 48 hours in advance. I do know some clinics that are doing their pre-visit planning much more than 72 hours, more than 3 days in advance. That works. That does reduce some time pressure in terms of we've got 25 patients on the schedule and we're starting a day ahead. There's a pressure there. And if you think about that workflow, then you just need a way to get prepared for patients that are late add-ons. Patients are added the day before or the morning of. You need a process to handle that. If you're lucky and you have an EHR I've never heard of, then maybe this is automated and electronic, and your EHR, based on your schedule tomorrow, spits out a pre-visit planning sheet when you ask for it, or automated, as all the data you need, minus looking at what else happened, looking at who the patient saw, were they in the ED, what specialist did they see, what records do you need to see, that sort of thing. By and large, I'm not aware of that really happening anywhere besides some custom solutions. So in most cases, including here at St. John, it is mainly a paper-driven manual process. And it's the work of optimization and improvement, moving it to increasingly automated in the future. So this pre-visit planning is, as I said, kind of the keystone of team-based care. It is the key to being proactive and not reactive in our care. From an efficiency perspective, it prevents what I like to call landmines. When you walk in to see Mrs. Smith, and she's been to the cardiologist and wants to know the results of the testing, and you don't have the echo, and furthermore, you didn't know she was at the cardiologist. That's a landmine. And then you spend much more than your 15-minute appointment scrambling to figure out what happened and what's going on. You don't need more than 1 or 2 landmines in a schedule in a day to essentially blow up your workflow. And suddenly you're 30 minutes late for routine of patients, and it's very, very hard to recover from that. And this prevents most of that wasted visit phenomena that you don't know what the patient's asking about happened, you don't have the records you need. There was supposed to be a diabetic follow-up, 6 months or 1 year, but the patient doesn't have a lab done, so you really can't answer any questions or make any changes. That leads to doing everything after the fact, which then generates tremendous work and rework as you try to call the patient back with lab results. The patient's not going to leave a message, call you back, you call them back. Some time motion studies I did in my practice showed that the average just call patients about lab after the fact, as opposed to having it available at the visit to discuss live, created 3.5 contacts and 25 minutes of work every time that happened. And this is the way you circumvent that. So by extension, the pre-visit planning greatly reduces patient and clinician frustration, because when the patient's with you live, you're prepared to fully deal with the issues the patient has and make decisions, as opposed to find out the data and then try to contact the patient for decisions later, or schedule another appointment that just increases your cost of care. It's a way to improve patient satisfaction, and I've experienced that powerfully, that when your care system is hooked up this way, patients highly value and love their visits because they know when they come in, we're getting stuff done, we're making decisions, and you have the full time to talk about the patient's issues as opposed to catch up. It does reduce provider satisfaction, especially the chronic disease visits. It just made chronic disease management visits much more productive and satisfying, because I felt like I was prepared for that engagement 95% of the time with the information I needed to advance the patient's care, as opposed to prepared 25% of the time. By extension, it is the key to optimal chronic disease, as I mentioned. So a traditional schedule and the traditional concept, and the quote we mentioned at the beginning, this is really a change of mindset of how you approach a visit, or even the concept of what is a visit. The traditional visit is kind of an episodic reactive engagement. The patient shows up, you, based on a chief complaint, and what the patient says when you walk in, you react, you find things, you scurry for records you don't have, you figure out the patient obviously needed lab that's not done, and that leads to each visit, you're out of time, gaps of care are either missed and not recognized, they're recognized, there's no time to deal with them. How many times you have a female patient with you and you clearly know she needs a pap smear, there's just not time in the visit, and you can't ever get the patient to schedule it to come in. And it's just kind of an opportunity wasted. You dealt with a complaint, you might have dealt with 5 problems, but there were all these other needs at this visit, and the visit was the live opportunity to deal with it, and part of that opportunity was wasted. So then in this traditional episodic flow, there's a visit, you react, find, and scurry, and the patient walks out the door. And there's a void, and the void can be filled by phone calls if the patient calls in, or phone calls if you call out. But then the cycle starts again at the next visit. Patient walks in, we look at a chief complaint, we react, we find, we scurry. Again, the visit ends without you having time to really get into behavior change and motivational counseling for the tobacco. Despite the cabbage and the diabetes, patients overweight and smoking, and you just never seem to have the time to deal with those hard problems, right? That's the traditional experience. The pre-visit planning and advanced rooming looks at visits as a continuous engagement. So you're continually thinking about this relationship as a wheel, essentially. So it starts with pre-visit planning. So there's a checklist. The last visit's reviewed. Are there missing records? Was there a specialty visit? Is there a discharge summary? for what the patient has going on, not necessarily what they schedule the appointment for, but for what the patient has going on, their medical needs. Is there gaps in care? Do we need lab before the visit? If there's some needs, we make a pre-visit contact or pre-visit phone call. We need to do some depression screening and a fall screening at the visit you're coming in for your hypertension. So please come in 15 minutes early, whatever they may need. Then there's a huddle the morning of the visit, and then that information is handed off to the provider. Okay, then there's a visit, and you do the medical care you do, and part of that will be advanced rooming. We'll talk about the advanced rooming talks about kind of what's the huddle and the handoff of this critical information to the provider. Then there's post-visit planning, which starts essentially at the end of the provider engagement and links to the provider or staff doing things immediately before the patient walks out or just after the patient walks out. And that's a post-visit planning checklist essentially for the patient I just saw. When do we need to see him next? Place any lab, med, immunization orders needed to be done before that next visit. Provide any anticipatory counseling, make referrals if you need to. At the end of every visit, make any refills you need to make that will prevent any phone calls before the next visit. And set any reminders. There was a not indeterminate nodule on the CT from the hospital 4 months ago. It needs to be rechecked in 2 months. So set a reminder, set a tickler with your nurse, whatever system you use. Then in between those two, it's not a void, it's a maintenance phase. Patient initiates contact. You have results, lab results coming in before, I usually recommend a week before the visit. You have results coming in. You're working your lists of gaps in care. You're continually kind of reviewing that population health view of your patient and your patient population, and that fills the maintenance between visits. So it's a continuous, proactive type of relationship engagement. So there's kind of 10 steps to think that through. So at the end of the current visit, you schedule the appointment. Don't saying, okay, we want you to call in 3 months to schedule is just another contact, and then the nurse is busy and you take a message or it goes to voicemail, you call the patient back. I want to emphasize every single phone call generates 3.5 contacts and 20 to 22 minutes worth of work for a medical assistant, nurse, or phone personnel. So just schedule the patient to come in when they need to come in. If you have open access, universal access that works for you, you can say walk in 6 months and we'll be able to see you and do your lab a week before, and that system can work too. So you use a visit planner checklist to make sure everything's covered. Order and arrange for laboratory to be done at the right time frame before the next visit. For the next visit, so we skip over the maintenance. We're now at the pre-visit phase. You do the visit preparation, use the pre-visit checklist for all the things we talked about. You send any patient reminders or phone calls. If you're doing this several days in advance, it's a chance to close any gaps or knowledge voids identify. And then at the visit, you quickly kind of have a team huddle in the morning to read the schedule, and then you do advanced rooming, and then the provider takes over from there. This is a very target-rich environment, and what I mean is there's lots of good stuff to use pre-visit planning and advanced rooming to get to. Includes all the preventative care issues. It empowers your advanced rooming. It includes anything that's a chronic disease metric that you're wanting to improve. So all of your ambulatory sensitive chronic conditions from your ACO reports, those all can be powerfully improved by changing your concept of how chronic disease happens. There is a good so this target-rich environment fosters the conversations we need to be having. And what I mean is, if you decide from your data that, boy, CHF readmissions is an issue and we want to do better chronic disease for congestive heart failure, just waiting for the patient to come in with CHF and say, okay, I'm going to try harder for this patient isn't a systematic way to improve, and actually it doesn't work. For diabetes, if you're looking at diabetes uncontrolled measures, thinking when the diabetics will come in, I'll work extra hard or change their mind to take their medicine, again, isn't a very effective strategy. So we could approach this much more systematically, and that leads to conversation. So for all the folks in an office, this only works if there's a standard, and that's the conversation we need to be having. And the example is, so for diabetes, if we're gonna take on diabetes, what is the basic minimal standard that everybody can agree on? Something I've used before, which worked really well for us, was to say, okay, we consider controlled for the sake of operations. We consider controlled is less than 8 and uncontrolled is greater than 9. Obviously, uncontrolled is defined by your CQMs. Controlled is not. But there's some disagreement and conversation about is standard controlled is less than 7. Well, but for a 75-year-old who's frail, maybe that's too tight, and so maybe controlled is less than 7.5. Well, there are a couple of payer programs that measure a A1C less than 8 ratio, so it keeps you from getting bogged down, frankly, in debating angels on the head of a pin to say, for our purposes, we're going after uncontrolled, and we agree uncontrolled is higher than 9. So then what's your workflow for that? We agree for uncontrolled diabetes, we expect visits every 3 months until it's controlled. And we want an A1C done every 3 months before the appointment. So at the time the patient comes in, we can make a decision, not order lab and create more phone calls and more work and rework. If you have point-of-care A1Cs, that works equally well. The MA can do a point-of-care A1C when the patient shows up. That is a great workflow. If you don't have that, that may be something to look into. And then lastly, for uncontrolled, we agree if the patient has been in usual care, I've been trying my hardest for 6 months or 9 months or 12 months or whatever time criteria all the partners agree to, then we're going to plan an automatic referral to diabetes education or a clinical pharmacist, PharmD, to dig into medicine. And that's been shown both in research and my experience to be a really, really powerful way to get at diabetics that aren't controlled. And for controlled diabetes, we agree to have a visit every 6 months and an A1C every 6 months. And then you can take it a step further and say if they're controlled less than 7.5 and they've been that way for more than 2 years, we agree to back it up to just a visit once a year, for instance, right? So you have that conversation. Each site has to come to agreement of what the least minimal standard everybody can agree to is, and there will always be anecdotal exceptions to that, and that's okay. But once you do that and have that agreement, you can create standardized pre-visit planning and advanced rooming tools that helps your team drive the care you need. Discovered in preparing for this a really pretty good AMA education module about pre-visit planning. There is the web address. I think it is worth people's time to work through it. There's actually a slide set to get it, and some good resources or tools, some of which I will show you, others are there for your use. One of the quotes there is that in internal medicine practice in Boston found by simply changing laboratory testing from reactive after the visit to have to call the patient to pre-visit laboratory testing, reduced letters and phone calls by 80% and saved in time $25 per patient visit in just staff and physician time. And I would say at Via Christi, in our journey towards NCQA certified medical home, I experienced exactly the same thing. It completely collapsed our phone work and rework. And so the medical and nurses, as opposed to being stuck on the phone all day, were available to help engage with patients, do some nursing visits. It was really a very gratifying and freeing experience for the staff too. There is a pretty good pre-visit planning case study here, which we're going to watch. Let's see if this link works. This is just about a minute and a half. Okay, is everybody hearing the sound or no?
No, we're not.
Okay, see if I can get that. Hearing it now?
Still not hearing it.
Technical difficulties. Okay.
We're seeing the continuous engagement. The next visit begins today. Slide.
But you're not seeing the video?
No.
No.
Oh, so hang with me. That's a presentation issue. And seeing it now?
Not yet.
Okay.
Is your screen frozen?
I'm trying to get that link to work. Nope, not frozen.
Okay.
Just the link is not working, and I need to change screen that you're seeing, and I'm not figuring out how to do it. Well, my apologies. It's a good video. We will let people play it offline.
Will you give us the link to that?
Or is it in the PowerPoint?
Absolutely, and it's when you pull up the.
If you minimized your presentation, would it show on your screen? He's got to share that out.
Let's see. Okay, let's try this. Are you seeing the main slide still?
Yes, the continuous engagement, the next visit begins.
So you're not seeing a new window with the video?
No, we're not.
No. Oh, well, my apologies. Yes, the link is there, and if you go to the AMA Steps Forward pre-visit planning, it's the link I previously used. The case study is right there. It's a minute and a half long. It's just a testimonial to what they experienced as they went through this process. So, tremendous time savings, tremendous benefit to the practice, and patients like it better. So overall, the benefits are, as we mentioned, this is a quote from Lee Mills, that the telephone is the devil. It's the single, paraphrasing the Waterboy just a little bit, it's the single greatest self-fulfilling time use in the practice. It's in our control. Just by doing things so you can handle lab and radiology results live, by ordering known lab before chronic disease visits, and then by hooking up incoming phone calls to be handled live without messages or calling anybody back. It's an organized approach, makes you feel more proactive, and then the team systematically finds gaps in care that can be addressed. So let's take that forward one step to advanced rooming. All right. Well, I guess we're back. I'm not sure how or why it got frozen, but we'll go back to where we left off, and whoever's hung in with us, we can resume. Okay, so you're saying this is where we're hung up.
I see traditional, episodic.
Yeah, that's where it froze before.
That's where you froze.
Yeah,
okay.
Continuous
right.
engagement.
Gotcha. Well, so we talked about there were my deepest apologies for the technical problems. It's curious doing it the same way we've always done it and never had troubles before, but here we are. So I did mention there were kind of 10 steps conceptually. We're not going to belabor that. Target-rich environment, just saying that there's many things you could do pre-visit planning for. Preventative, chronic disease care. As you start thinking about approaching this or increasing what you're already doing, you don't take on everything. Conditions off your quality reports and off your utilization reports, and off, frankly, the things that affect your patients' lives the most. So we talked about this fosters the conversations that we need to be having to affect pre-visit planning and advanced rooming within a given office, whether it's a pod or a building. Essentially, you have to say what we all agree to, because it's not effective for your staff to do pre-visit planning with 3 different standards, right? And so we went through those. I used diabetes as an example, and obviously there's lots more that you could bring into a signed kind of standard of care or order set or whatever your state regulations call it. Just a care pathway is what we wound up calling it in Kansas, is what we call them here. And once you have that agreement and assigned care pathway for the staff to act on your instructions, then you create pre-visit planning and advanced rooming tools. So I mentioned this AMA website with the training. There is the web link at the bottom. Now I understand how you never saw it. It is darn good, actually, and the video I was trying to show is on that front page that you visited. It's about 1 minute and 45 seconds, but worth watching. So this internist talked about when they rearrange their chronic disease care to be anticipatory, to have all the lab in advance of each chronic disease visit, they saved 80% of their phone calls. And I just was sharing that my reflection, my experience reflected that exact thing. Here's the video I was going to show you with the link in the slide that works on an individual computer. It didn't work being rejected for some reason. And so the benefits, pre-visit planning. The benefits are dramatic reduction in phone calls and therefore time, a much more organized approach to care, where the effect on the care is really visceral. You feel that you're more organized, less reactive, less scrambling after the fact, fewer visits where the doc doesn't have all the information they need at the time they need it. And that really changes the culture and how a practice feels. And then it enables the team, not the provider, but the team to systematically find gaps and to take care of them without having to be specifically told or directed at every patient. And I am confident most of the practices on the phone are doing some of this already. And so this is just approach to even make it more mature and more robust. So the flip side of pre-visit planning is advanced rooming. And when you have your pre-visit planning check sheet or flow sheet or whatever you like to call it, you have it done, the patient shows up, what do you do with it? What you do with it is advanced rooming. So that's the practice of regularly addressing routine, perhaps rule-based, or high-priority issues at the time the patient is being roomed. And what I mean is it lets your medical assistants and your nurses focus on issues that they can successfully accomplish for the team, often before the provider even gets to the visit. In my practice, if the patient needs a pneumovax or a fall screen, that's done before I get to the exam room because we know it, we have a care pathway signed for the staff to act on it, and it happens automatically. If I happen to be really caught up that day and I get to it before they finish, I go ahead and start my encounter, and then they come in right after and act on it, but I don't have to do an extra step to tell them about it. If a mammogram is done, the mammogram's ordered. If colorectal screening is necessary, we've got a standard sheet that nurses and MAs use to talk about. We need colon cancer screening for you. These are options with relative advantages, disadvantages, pretty simple 6th grade language, and to say, okay, if you accept a referral for a scope, or we'll schedule you for a scope if we do them, done. If they don't do that, will they accept a fit card? If they accept a fit card, they already have it before I get to the room, done. Therefore, my engagement is actually able to focus my time on the patients that are resisting colon screening, that I can have the motivational interviewing conversation that needs to take place. And I knew it before I got there. Then if lab is done, if obvious lab is done, then the lab orders are entered preliminary or they're queued up for me to sign. So advanced rooming, as I said, is a rooming checklist of items that the team intends to provide and to review for every appropriate patient every day in a highly reliable fashion. It uses the work product of pre-visit planning, and it's kind of the key to actually acting on and harnessing the power of your team. We talked about, using team-based care and pivoting from doctor and the MA doing everything, and I'll get it. How you actually do it is right here. Here's an example of a medical assistant advanced rooming checklist, and I mean, almost everybody has a face sheet or you use when the patient goes in the room. This is just increasing to the items that you want to cover for every patient and have done automatically following your internal rules if you want to. The advanced rooming checklist or pre-visit planning checklist, then used for advanced rooming here at St. John Clinic, has about 17 items on it, and we've been kind of perfecting it. It's definitely PDSA in action. You start with a few things and expand it. When you find out you've got too many things, you narrow down to the most important, and it's kind of a living document. Here is another example that I practiced. It started being developed in 2006. It was a cornerstone of our chronic disease care, leading to NCQA Level 3 recognition. And we called it our chronic disease report card. And so this was the pre-visit planning checklist, basically, for every chronic disease management visit, focused on diabetes, hypertension, dyslipidemia, obesity, and tobacco. And the data was recorded. The lab was done in advance of the visit. The lab was updated. We gave it a letter grade. Those brackets of, what blood pressure is an A was arbitrary. The partners just picked numbers that made logical sense, but it really helped foster a conversation. The patient didn't want to see that their blood pressure was a C. That meant way more than their blood pressure at the visit was 152. It helped it transfer it to patient language. We put the prior lab down, so we not only talked about where you are today, we could talk about where you came from when the last lab was done 3 months, 6 months, 12 months ago. It had all the standard preventative care vaccinations on there. The standards for hypertension in terms of statin, ACE-ARB, aspirin, diabetics that tracked our eye exam, our microalbumins, our foot exams, and then when documented on this report card, it became an engagement tool with the patient. The patients came to where they really wanted their straight A report card for their chronic disease, and I had innumerable patients tell me they were referred after starting with C's and D's and working on it. So it starts with pre-visit planning, it winds up being an advanced rooming tool, and then it winds up being an incredible patient engagement tool. Then here at the bottom, you wind up working on actually starting that continuous cycle of visits. So at the end of the visit, you talk about what needs and support are there. Is there any medication changes for today? And then when's your next visit? And then what lab do you need to come in for the next visit? And then the patient has that with them when they leave, and the team has visibility about what's happening. So it was a remarkably effective tool, and it got our diabetes uncontrolled down less than 10%, got blood pressure in control above 80% at the time we were using it. Mainly the satisfaction of patients skyrocketed, and we felt dramatically more prepared and comfortable with chronic disease care. So here's a slightly different take on the same concept. This is just one of my offices currently has just lined out all the things the MAs do at the time of a visit and what are the tasks the provider does at the time of the visit. And so it's just a way to line out who's doing what portions, what do we intend to emphasize and do every visit every day. So lastly, advanced rooming, I want to speak to the elephant in the room. Absolutely, it can slow down rooming. That is true. Right now at St. John, like I said, 17 measured things, pre-visit and advanced rooming items, including fall risk, so it's ACO and CP plus items, fall risk, depression screen, all the standard preventative cancer screening and vaccinations, and then chronic disease, diabetes, hypertension, and CHF is what we do now. Average rooming time for an experienced MA is about 7 minutes. New MAs that we're training up to do this, rooming time is about 10 to 11 minutes. And so if you're looking at a rooming time of 3 minutes now, you say, golly, that's that tremendously slow things. And I just want to point out that it is balancing meeting goals. Under the old paradigm, without value-based payment, just worry about throughput and getting out. Now with value-based payment, especially if you're getting comprehensive primary care dollars, then you balance in consciousness and planned care. So it's not either or, and don't approach it as either or. Approach it as kind of start stepping into this and then work through it as it proves useful. Excuse me. One thing I do want to say is that there is the basic quality improvement lean management precept, which is there is no improvement without standardized workflow. If you've got a 6-provider office and everything does stuff different, you'll never really know what's random variation and what's true cause. And when you change something, you'll never know if it got better randomly or it got better because of what you did. It also just leads and enhances chaos and complexity. And so I can't emphasize enough, just getting agreement, standardizing these workflows is very powerful. And lastly, if you can't measure it, you can't improve it. When I started this quality journey, that just seemed like a cute, trite expression. Now I'm 100% convinced is completely true. If there's no number or no metric or no measure, you really will never know if what you did made a difference besides people's impression, which is wildly unreliable, part of them. So there's many metrics you could use. Average time to room, average number of gaps in care. You identify as a room, meaning as you improve this, you'll start seeing average gaps in care at the time the patient shows up declining. You see quality metrics improving. Percent of patients roomed for whom they're ready for the visit and you're prepared to visit. One we tracked was chronic disease patients of whatever the named problems you want to focus on are, percent of patients who have their lab done in advance. And that's an incredibly single powerful tool. Okay, so to back up, this idea of pre-visit planning and advanced rooming embodies the team ethic and the mood to be anticipatory and proactive. It acknowledges the reality that there's not enough time in the day for the provider to do it all, and yet we're still reliable for this, the sum total health of our population. And so this takes those two realities and starts figuring out how to make it happen. It does move the culture from my practice to our practice and my patients to our patients because everybody's working on the patients together. It's incredibly powerful. It does provide an easy opportunity and an early opportunity, especially when you start nibbling at this, don't start huge, small, to trust and train your staff and then analyze and adjust the workflow as things start getting better. And then it does dramatically improve rates of optimization, of optimal preventative care and chronic disease care. And I certainly have lived with that. So, gets the whole team in the boat going the same direction, and that really can be practice nirvana. It changes the whole field of practice, and patients love it. So that's it for today. I apologize for the technical difficulties. We've got 5 to 7 minutes left for questions if there are any. I'll turn it back over to Jolene.
Are there any questions from anybody? I guess I have one while other people are thinking about it. is there a chance that we can get those papers of the ABC and those things? Can we get that in a Word document or something that we could use?
Absolutely. I'd be happy to share those.
Okay. We did get a question.
Yeah, the diabetes report card is my personal creation, perfected over nearly a decade, and it was an amazingly powerful tool.
Okay.
It is an amazingly powerful tool.
Okay. We have a question. What is the minimum number of team members per provider this would require, and how much time is allowed for each appointment?
Great question, and I don't think there's an answer. I guess what I mean is you have to do pre-visit planning and advanced rooming with the team you have. It's a little bit like the old military saying, you go to war with the army you have, not the army you want. So that's just balancing your available workforce with the time it takes to do this. Start small and work into it. But realize that the way you create more space, more time for your team to do more of this, is start doing this and crash the number of phone calls. That's a huge dissatisfier for most of our clinical staff. Feel like they waste a lot of time on the phone, and that's the time you harvest to do better stuff. And so you just start this process somewhere and move it forward. Most people that do this, it's not like you're hiring lots of extra staff. So if you're in a 3-doctor pod and each doctor has an MA, maybe there's a single nurse care manager in that pod. That's the situation I was in using the full pre-visit planning and chronic disease report card that we did all the time.
Are there any other questions? If you want to ask, instead of going through chat, please click on your telephone or your unmute and unmute yourself and ask.
While we're waiting for that, I'll just say a great way to start is look at your ACO metrics. Pick the preventative metrics, 2 or 3, that you most need to improve or that you most need to move from wherever they are to some other threshold to capture your value-based payment. And the same thing, your chronic disease, ambulatory sensitive condition metrics, just pick about 2 and then build your pre-visit planning sheet to be sure you look at those things ahead of every visit, every patient, and then you do the very rudimentary care signed by the providers at the practice so that the staff can act on those instructions whenever it's germane, every visit, every day. And that's pretty stripped down and pretty lean. Wouldn't add much time to standard practice, and it would still start getting you bang for the buck.
Okay.
I don't hear anything.
I don't hear any questions, so thank you, Dr. Mills. We appreciate your time, and we will talk. So thanks, everybody.
Okay, thank you. Appreciate everybody's time.
For those that have signed on as False City or whatever, please take and let me know who attended so that we can get you the CMEs. We need to know which providers were actually on. So thank you very much.